So, good evening everyone. So, we are going to discuss the next topic. So, everybody will be wondering why inflammation can never be a friend. So, Professor GVK has given me the topic. We'll discuss whether a foe can be made a friend and what basic understanding of inflammation and diabetes we should know before going into the aspects of inflammation in diabetes. So, I will touch upon, so as per the requests of Guru, I will have to cut short my talk before already we are running late. I will make it precise and simple what we should know about inflammation and diabetes and how inflammation can be used as a target for defeating or decreasing the inflammation in diabetes. That's what we are going to, that is the crux of my talk today. We'll be discussing about what are the inflammatory pathways. Are there any biomarkers of inflammation? What are the specific biomarkers of inflammation and diabetes? How does inflammation differ in type 1 and type 2? Is there any benefit or are there benefits of inflammation? What does inflammation suggest us for therapy and future strategies? I'm just touching upon the inflammation in type 1 and type 2 separately, but what we should know is, we should know 3 cytokines, starting from interferon gamma and the innate inflammatory cytokines TNF alpha and IL-1 beta. Apart from this, the combination of action of all these inflammatory molecules result in upregulation of INOS, inducible nitric oxide synthase, which promotes inflammation in higher concentration. Reactive oxygen species, much talked about everywhere, starting from all complications, starting from NAFLD and other complications. Initially, it was implicated, but now there not be a direct effect on beta cell. So, this is what is the summary of inflammation in type 1. It starts from B cell, T cell, macrophage and natural killer cells. 3 important cytokines we have discussed, which causes direct damage to the beta cell and ROS doubtful through nitric oxide, increased nitric oxide synthase. How does it differ in type 2? So, type 2 we know, type 1 is definitely inflammation and genetics. In type 2, if it is C, there is a metabolic component, but the correct term is there is a subacute chronic inflammation caused by stress activated JNK and NF kappa B. These are the 2 important mediators. Along with that, there is a metabolic component, that is an obese patient. You have adipokine secretion, excess adipokine secretion, which stimulate additional inflammatory responses in obesity and promote obesity-related metabolic and cardiovascular diseases. The next aspect is whether brown and white adipose tissue. Brown is a good one, which helps in good homeostasis. In contrast, white adipose tissue, especially visceral and the upper trunk, what happens is they are the major sources of inflammatory source of in diabetes, major source of inflammation in diabetes. Various cytokines, all are theoretical, theory is always boring, still these are the important cytokines. In the next picture you can have an idea what are the good cytokines and the bad cytokines and what do they do. Next 2-4 slides of pictures where how inflammation, the problem with inflammation in type 2 is it not alone destroys the beta cell or exhausts the beta cells, it has effects on other organs. That is the worrisome picture in type 2 diabetes, starting from muscle causing sarcopenia, adipose tissue, stimulation, pancreas, anyway we know, liver dysfunction and gut. This is what we should know. Adipose tissue, you have excess fat. What happens? Beneficial effects are by leptin and adiponectin. Deleterious effects, advanced glycation end products, plasminogen activator inhibitor 1, PI1 and interleukin 6, TNF alpha, ASP and resistin. These are the deleterious effects which causes various effects on various organs. So what is the right slide is white adipose tissue. No need to memorize. The problem with adipose tissue is, apart from insulin resistance, it can't predispose to other metabolic and immune diseases. That's what is the problem with obesity. Gut microbiota, Vijay sir had just spoke about what happens with the gut, but only two important things we should know about gut: lipopolysaccharide and short-chain fatty acids. LPS causes low-grade inflammation, while SCFA, short-chain fatty acids, modulate gene expression through human monocytes and reduce pro-inflammatory cytokines. So SCFAs are beneficial for the patient. This is what is dysbiosis and homeostasis. Why we should know all the details of inflammation? What is important is, with this, the ultimate thing is there a marker by which we can address early inflammation and target diabetes and control diabetes. That is what is the idea of inflammatory markers in diabetes. So dysbiosis, we always know, you can see bacterial translaction. That's what is the exact term, which causes increased permeability and increased LPS in the gut due to various altered gut microbiota. With, you can see various markers which can be elevated and decreased. If you go into it, there's a decrease in GLP-1, increased TNF, increased IL-10, increased IL-6, which causes decreased SCFA with dysbiosis, where there is increased permeability, increased slack, and LPS. This is also important. I'm not, though it is a theory, what happens with diabetes is, this picture will clearly say, there is a classical M1 macrophage and an intermediate. Both will cause inflammation. M1 causes severe inflammation, intermediate causes subacute inflammation, but both are deleterious for the body function. With various markers and what are the cytokines specifically they produce is in this slide. If you compare with M2 macrophages, they are beneficial, which causes resolution of inflammation by various mechanisms. What happens in with the monocyte dysfunction in diabetes is, that's what is, there is a phenotype switching of macrophages from predominantly anti-inflammatory M2 to M1 and intermediate M1. That's what happens, which plays a role in initiation of and amplification of islet inflammation. So to summarize, there is inflammation in both type 1 and type 2. The difference is here it is pure with a HLA association along with inflammation, which targets the beta cell. There is autoimmune destruction of beta cells, very clear. In contrast, in type 2, there is a gut involvement, adipocyte involvement, liver involvement, and macrophage activation, which causes augmentation of inflammation. And the physiology is increased apoptosis, increased beta cell dedifferentiation, and decreased beta cell mass. Dedifferentiation, we had other talks on dedifferentiation. Cell component can change to other cells and come back to beta again. That's what is dedifferentiation. Coming to the talk, whether it's Rajinikanth or the villain, so we'll have a summary of whether it is a friend or foe. Theory. In theory, these are the markers of inflammation. If you have a very good setup, a research institute where you can do various markers which are feasibly done. Not all markers, you can see the markers. Broad term is, we have discussed adipokines, we have discussed cytokines. The two others is hepatokines and others osteocalcin, irisin. So these are good molecules. You can see blue is anti-inflammatory, red is pro-inflammatory. So what is the level, whether it's decreased osteocalcin is anti-inflammatory, increased irisin is anti-inflammatory. That's what is the picture. We are not going to detail of all, almost 10 minutes is over. We have to complete by 5 more minutes. I'll make it simple. This cytokines is definitely there, which causes beta cell failure, type 2 diabetes, all can cause insulin resistance and metabolic syndrome. Adipokine through insulin resistance causes metabolic syndrome, or it can go to type 2 DM. That's what is the crux of this inflammation theory. So I am always a practical person. I always want to know what I can do in practice. We have various theory and all markers are available. In practice, will I have a marker? What is a definite marker to say there is inflammation diabetes, or early markers to suggest inflammation diabetes? If you go, these are the markers, but if in the restricted setup, the patient is not going to afford fasting insulin, vitamin D3 may not be feasible in all patients. All others are almost affordable. This NLR is a simple one. It is only from CBC. We do CBC for all patients. NLR is a very specific marker for inflammation. If it is above 9, it definitely suggests there is a marked inflammation. Above 3 is significant. Above 3 to 9 is a gray area. Still, 3 to 9 is there is definite inflammation. So you can HSCRP more than 3, ESR ferritin more than 337, LDH, homocysteine. This homocysteine we are all do for patients, especially when the patient is having a thrombotic event, whether it is a CVT, whether it is a stroke, all patients we do a homocysteine level. Inflammation is never a friend. It can never be a friend. But this inflammation will teach us how to reduce or how to treat diabetes or perform future strategies to prevent inflammation. So we know that there is inflammation in diabetes. How do we reduce inflammation? It is always a foe, but with understanding, proper understanding, you have a specific therapeutic target to reduce inflammation. Then it becomes a friend. So type 2 DM, there are various, this is again theory, what were the various molecules. Practice, it's not, cannot be used. Still, we should know what is happening in a research. What is there is gene-guided modulation of PTPN2 gene. That is the most important for type 1. Followed by rituximab was tried, but not rituximab has all side effects. We are not going to discuss that. Plasmid DNA vaccination and teplizumab and otilimab, where anti-CD3 monoclonal antibodies which have specific functions, special effects to improve inflammation in type 2 diabetes and preserve the beta cells. Yes. Type 1 DM, other molecules what were tried is etanercept, which is used as a IL-1 therapy, anti-TNF, and other IL-1 therapies were tried. And alpha-1 antitrypsin can be tried. For Indian setup, vitamin D definitely has a role. When there is a deficiency, you always treat vitamin D. It may have a good effect on glycemic profile. Aspirin, low-dose aspirin, has definite effects on inflammation. Though we are reluctant to use in all patients, various studies are there. But if you feel there is a strong inflammatory marker, multiple strong inflammatory markers there in a diabetic patient, aspirin, in a low-dose aspirin, definitely can ameliorate inflammation in specific patients with all other comorbids. Other theoretical aspects may not be used, but what we should know is canakinumab. That is what is the CANTOS trial, but it did not show much effect. Definitely there is a effect on reduction of inflammation. Whether it is going to affect them in long-term glycemic control. What they found is when there is a high cardiovascular risk, this molecule had an effect on reduction of cardiovascular risk, but there is no effect on HbA1c, glucose, and insulin at 4 months. So there is no point. Just inflammation is not going to help. I'm not going to. Just we have 2 important slides with some aspect on practice. So what is for my regular practice? What will I do? Can I use some specific molecules? Definitely. PPAR agonists, statins, aspirin, along with ACE/ARB. They have specific effects on inflammation and reduction on diabetes. From diabetes or inflammation to thrombosis, we have various. Aspirin, statins, clopidogrel, we know. A few antibiotics. From diabetes to atherothrombosis, definitely PPAR agonists. We are always worried about pioglitazone toxicity side effects. Low dose pioglitazone is a wonderful molecule. You can always try in specific patients with severe inflammation. Metformin, always know, always a time-tested drug, AC and antiplatelet drugs. So I'm not going to this. So anyway, to what is happening in research, just wanted to show there is a low-dose IL-6, which has been tried in diabetic neuropathy, which had specific effects on remyelination. They were found, we always say, when demyelination is there or some involvement of the nerve, there is no regeneration. They have found there is a nerve regeneration. It prevents and has a good profile on worsening or retarding the progression of neuropathy. That's what is the picture says. I'm not going to. So the last slide is, what is a summary from my talk, from this talk? You have target therapies. You target inflammatory pathways to prevent or control diabetes and its complications. Type 1 is always an immunological response rather than a metabolic disorder. You have to target the immune system, which is not practically possible. If it is type 2, we always have PPAR agonists, ARBs, statins, DPP4 inhibitors, aspirin. Have a significant role in reduction of inflammation. The last is micronutrients. So we always forget micronutrients. We have various micronutrient deficiency which can worsen inflammation in diabetes, which can worsen glycemic control, along with vitamin D, and it has to be individualized for a patient. The last is always there. Indian scenario is a cost-effective one and a reasonable anti-inflammatory therapy with minimal adverse effects. Thanks for the opportunity given. Thanks, Professor GVK, for the wonderful opportunity.